Welcome back to the Deep Dive. I hope you are ready to focus because today we are wading into some pretty heavy waters.
We really are.
We're looking at a topic that touches almost everyone in some way. Maybe it's personal, maybe it's a family member.
Or maybe it's just by virtue of existing in a society where this issue is, well, on the news every single night.
We are talking about substance-related disorders.
It's a massive topic, probably one of the most complex things we deal with in medicine because it sits right at that intersection of biology, psychology, and, sociology.
Right.
And I think it is really important to state right off the bat what this deep dive is and maybe what it isn't.
Okay.
This isn't a moral lecture. We aren't here to wag a finger and say, don't do drugs. That's not useful. And frankly, it's just not interesting.
Exactly. We're trying to get away from the stigma and the just say no slogans. We want to look at the clinical reality. We're treating this as a deep exploration of human neurobiology. We want to understand the behavior and the medical mechanisms of what actually happens when substances, well, hijack the body's systems.
Hijack is really the perfect word for it.
Yeah.
It absolutely is, because that is what we are seeing. The brain has these intricate, beautifully designed systems for survival, for reward, for pain management, for alertness. And these substances essentially come in, kick the driver out of the seat, and just floor the gas pedal.
And to guide us through this hijack, we're looking at this through the lens of a comprehensive medical text, specifically Chapter 71 on substance-related disorders.
A really dense but very thorough source.
We're going to be decoding the DSM-5 classifications, which can be a bit dense, so we'll try to translate that into plain English.
Yeah, we'll break it down.
And we're going to understand the physiological impact of 10 separate classes of drugs.
We're covering the whole spectrum. I mean, from the things you might have on your kitchen table, like caffeine and alcohol.
Right. Things we see every day.
All the way to the illicit heavy hitters like opioids, cocaine, and the weird world of synthetic bath salts.
And crucially, we are going to explore what the evidence actually says about treatment. Because I feel like there is a lot of myth-making when it comes to rehab and detox.
Oh, absolutely. A lot of misconceptions.
The mission here is clarity.
Yeah.
I feel like there is so much misinformation out there. People use words like addiction and dependence interchangeably, but they aren't the same thing, are they?
Not at all. Not even close, clinically speaking. And confusing them causes real problems in how we treat patients.
I can imagine.
I mean, people also don't realize that withdrawal from alcohol can actually kill you, whereas withdrawal from heroin, while it feels like you are dying, is rarely fatal on its own.
That's a huge distinction.
It is. We
Yeah.
need to unpack that physiology so that when we talk about these disorders, we are rooted in facts.
Speaking of facts, there was one detail in the source material that just stopped me on my tracks. I think this is the perfect hook to show people why the chemistry matters so much. We all know mixing drugs is bad. Don't mix uppers and downers, right? That's what we hear.
Right. The standard advice.
But the text mentions specifically mixing alcohol and cocaine.
Yes. The formation of cocathylene. This is a fascinating and, frankly, terrifying piece of biochemistry.
Right. So usually I think of mixing drugs as just having two things in your blood at the same time. You have alcohol floating around, you have cocaine floating around, and they are kind of fighting for attention.
That's the common understanding, sure.
But you're saying the body actually synthesizes a new chemical.
That is correct. Your liver does it. It's a process called transestrification. When alcohol is present in the liver, the metabolic pathway for cocaine actually changes.
Changes course.
Exactly. Instead of breaking cocaine down into its usual inactive metabolites, the presence of ethanol forces the liver to combine them. It essentially manufactures a third drug, cocathylene.
So your liver, which is supposed to be filtering poisons out,
is actually building a super toxin inside you.
that is just wild.
It's a chemical booby trap. Cocathylene is a completely distinct compound. It is psychoactive, just like cocaine, but it has a longer half-life.
Well, it sticks around longer.
It stays in the body longer. And significantly, it is far more cardiotoxic. It carries a much greater risk of causing sudden death than cocaine alone.
Wow.
You are essentially manufacturing a more lethal poison inside your own body on the fly.
That is the stuff of nightmares. And it's just one detail. We have a lot to cover.
We certainly do.
We're going to break this down logically. We'll start with the framework of addiction, the definitions, then we'll go class by class. The depressants, the opiates, the stimulants, and the hallucinogens.
And finish with treatment.
And we will finish up with the science of treatment. So let's start at the top, the framework.
The framework is crucial because the language we use in medicine has changed, and that change really reflects a better understanding of the brain. If you look at the DSM-5, which is the standard diagnostic manual for psychiatrists, it made a really significant shift. It no longer separates substance abuse and substance dependence as two different things.
That's a big change, right? Because I feel like in common parlance, the dinner table, we still use those terms constantly.
All the time.
Oh, he abuses alcohol, implying he drinks too much sometimes,
Yeah.
versus she's dependent on painkillers, implying she needs them to function. We treat them as different levels of severity.
We do, but clinically, the lines were just too blurry. It was causing more confusion than clarity.
Yeah.
So the DSM-5 has combined them into a single umbrella term, substance use disorder.
Okay, so it's all one thing now.
It's viewed on a spectrum mild, moderate, or severe. The diagnosis isn't based on how much you take, but on a pathologic pattern of behaviors.
Right.
And the text categorizes these behaviors into 4 distinct buckets.
Okay, let's unpack the buckets. I think this is really helpful for anyone listening who might be worried about themselves or, a friend. What are we looking for?
The first bucket is impaired control. This is the internal battle. It means taking the substance in larger amounts or over a longer period than was originally intended.
This is the classic, I'm just going out for one beer.
To waking up 3 days later.
Exactly.
Yeah.
It also includes the persistent desire to cut down but being unable to. That feeling of, okay, Monday I'm stopping, but by Monday afternoon you're using again.
That struggle.
Yes. It also covers the time spent obtaining, using, and recovering from the drug. If your whole week is organized around the substance, that's impaired control.
Okay. Makes sense. Bucket 2.
Social impairment. This is the external damage. Failure to fulfill major role obligations at work, school, or home.
Let's put a face on this. Let's say we have a guy, let's call him John.
Okay, so John misses his daughter's piano recital because he's hungover, or he calls in sick to work because he was up all night using... It's when the drug becomes more important than the social fabric of his life. It also includes giving up social or recreational activities. Maybe John used to bowl on Thursdays, but he stopped because, you can't drink at the bowling alley, or he just wants to stay home and use.
The world shrinks down to just the user and the drug. Bucket 3.
Risky use. This is using the substance in situations where it is physically hazardous, like driving or operating machinery. That's the obvious one.
Sure.
But it also covers continuing to use despite knowing that it is causing or exacerbating a physical or psychological problem.
So if John's doctor tells him, John, your liver enzymes are through the roof, you have to stop drinking, and John keeps drinking, that's bucket 3.
Precisely. It's the denial of consequence. It's knowing the danger and doing it anyway.
And the final bucket, number 4.
Pharmacological criteria. This is where the body gets involved. It involves tolerance and withdrawal. This is the body's physical reaction to the drug.
Okay, so if you're taking boxes in these buckets, you're looking at a substance use disorder.
Right.
But the text also offered a mnemonic that I found really, really helpful, the 5 C's.
Yes, the 5 C's are a great shorthand for recognizing addiction as a primary chronic neurobiologic disease. It helps us remember that this isn't just a bad habit, it's a disease state.
Let's run through them.
Okay, the 5 C's are chronicity, impaired control over drug use, compulsive use, continued use despite harm, and craving.
That continued use despite harm. 1.
Yeah.
That always feels like the clincher to me.
It's a big one.
Like, if you know it's ruining your marriage or your bank account or your health and you literally cannot stop, that's the disease in action.
Precisely. That is the definition of the hijack we talked about earlier. The logic center of the brain, the prefrontal cortex, says, stop, this is a bad idea. But the survival center, the midbrain, screams, go, we need this.
And the survival center usually wins.
It's wired to win.
Now, we need to pause here and really drill down on a distinction you mentioned earlier, the difference between physical dependence and addiction.
Yes, this is so important.
I feel like this is where the stigma comes from for a lot of chronic pain patients.
It is, and it's a tragedy. Physical dependence and addiction are not synonyms. They're related but distinct. Let's use an analogy.
Okay.
Imagine a grandmother who has been taking a prescribed opioid for severe chronic back pain for 5 years. She takes it exactly as her doctor prescribed. She never takes extra. She doesn't get high from it. She just gets pain relief.
Right, she's functional.
Perfectly functional. She plays bridge with her friends. She volunteers at the library.
But if she stops taking it, Cold turkey.
If she stops abruptly, she will go into withdrawal. Her body has adapted to the medication's presence. She is physically dependent.
But she's not an addict.
But she is not addicted. She doesn't have the compulsive behavior, the craving, the social impairment. She isn't robbing a pharmacy to get her pills.
Okay, that makes perfect sense.
Now, compare that to someone who is crushing that same pill and snorting it to get high, missing work, and stealing money to buy more on the street. That is addiction or substance use disorder.
So dependence is just biology adapting to a chemical presence. Addiction involves the behavior and the neurocircuitry of reward.
Exactly. You can be dependent on beta blockers for your blood pressure. If you stop them suddenly, your heart rate spikes. But we don't call those people addicts. We need to be very, very careful with that language.
Okay. And then there's tolerance. That's one of the pharmacological criteria.
Right. Tolerance is just the state where exposure induces changes that result in a diminution of effects. In plain English, you need more of the drug to get the same result.
The first beer used to give you a buzz. Now you need a six-pack.
That's it. It's the body trying to maintain equilibrium or homeostasis.
And intoxication.
Intoxication is the acute phase. It's a substance-specific syndrome. It causes maladaptive behavior during the waking state because of how it's hitting the central nervous system, or CNS. It's the being high or being drunk part.
Okay, so we have the map. We know what we're looking for. Let's start looking at the specific territories. The first stop is the depressants. And the king of that hill is, of course, alcohol.
The most common offender by a long shot. It is legal, it is everywhere, and it is incredibly potent pharmacologically. The text provides a very detailed breakdown of exactly what happens when you drink.
It starts with metabolism. What is the body actually doing with that beer or that glass of wine?
It's a chemical disassembly line, and it happens mostly in the liver. Alcohol ethanol is metabolized by an enzyme called alcohol dehydrogenase. It turns alcohol into acetaldehyde.
Acetaldehyde, that sounds
Nasty.
It is. It's highly toxic. It's actually a carcinogen. It's the chemical that gives you a lot of the hangover symptoms.
Ah, okay.
But usually it doesn't stay around long. A second enzyme, called aldehyde dehydrogenase, quickly turns that acetaldehyde into carbon dioxide and water, which you just breathe or pee out.
So it's a two-step factory line: alcohol to toxin, toxin to harmless waste.
A perfect way to put it. But here is where genetics come in. Some populations, particularly those of East Asian descent, often have a genetic variation that makes them lack a fully functional version of that second enzyme. So the factory line gets jammed at step 2.
Exactly. The first step works fine. They turn alcohol into toxic acetaldehyde. But the second step is broken or very slow. So the toxin builds up almost immediately.
And what does that cause?
This causes the Asian flush, a red face, nausea, rapid heart rate, headache. It's actually a protective factor against alcoholism because drinking becomes physically unpleasant very, very quickly.
That's fascinating. But for those whose factory line works, they can keep drinking until they hit intoxication.
Yeah.
The text has a table correlating blood alcohol concentration, or BAC, with effects. Let's walk through that, because I think people underestimate how quickly impairment sets in.
They really do. At a very low level, say 0.02 to 0.03%, you just have slight euphoria and a loss of shyness.
The liquid courage phase, the reason people have a drink at parties to loosen up.
Correct. But it escalates fast. By 0.07 to 0.09%, which covers the legal driving limit of 0.08 in many states, you are seeing impairment of balance, speech, vision, reaction time, and hearing.
And that's the tricky part, right? Because at 0.08, you might not feel drunk.
You feel fine, maybe just a bit buzzed, but your judgment and self-control are reduced. Your reaction time is shot. You think you can drive, but your brain is lagging behind reality. That's where the risky use comes in.
Okay, what's next?
Then you jump to 0.10 to 0.125%. Now we have significant motor coordination impairment, slurred speech, the classic signs of being drunk that everyone recognizes.
And if you keep going past that,
At 0.31%, you are looking at loss of consciousness. You pass out. And if you reach 0.40% or higher,
found bad.
that is the onset of coma and possible death caused by respiratory arrest. Your brainstem, which controls breathing, just shuts down.
0.4%. That's halfway to being 1% alcohol in your blood. That is an incredible level of poison.
It is. The text does the standard drink math to put this in perspective. One standard drink, so that's a 12-ounce beer, a 4-ounce glass of wine, or a 1.5-ounce shot of whiskey, contains about 14 grams of pure alcohol.
Okay.
In a healthy 70-kilogram man, that one drink raises the BAC by about 20 to 25 milligrams per deciliter, which is roughly 0.02%.
So 4 drinks, quickly stacked, could put that person right at the legal limit or even over it. depending on metabolism and time.
Easily. And that doesn't account for body weight, food in the stomach, gender, a lot of factors. Absorption begins in the stomach within 5 to 10 minutes. Peak concentrations hit 30 to 90 minutes after the last drink.
Now, here is where it gets really scary. Intoxication is one thing, but getting off alcohol is another. You mentioned earlier that alcohol withdrawal is uniquely dangerous.
It is the danger zone. The text is very clear on this. Alcohol withdrawal can be life-threatening. This is something people really need to understand. If someone is a heavy, chronic drinker, simply stopping cold turkey without medical help is incredibly dangerous.
What does it look like? Paint the picture for us. What happens to the body?
It starts within hours of the last drink. You get autonomic hyperactivity. That means the fight or flight system, which the alcohol has been suppressing for so long, suddenly wakes up and goes haywire.
It rebounds.
It rebounds with a vengeance. The heart races. That's tachycardia. You get profuse sweating, diaphoresis. Hands start to tremor.
The shakes.
Yes. But as it progresses, within 24 to 48 hours, it can get much, much worse. You can have hallucinations. Tactile ones are very common, like feeling bugs crawling on your skin.
Oh, that's awful.
Then it can progress to what's called delirium tremens, or the DTs. This is full-blown confusion, agitation, severe autonomic instability. Blood pressure and heart rate are all over the place. And the most dangerous part, seizures.
Seizures from stopping a drink.
Yes. Unlike withdrawing from, say, heroin, where you feel like you might die but usually won't, alcohol withdrawal causes electrical storms in the brain. These seizures can stop your heart or lead to permanent brain damage.
Why did that happen? What's the mechanism?
Think of alcohol as a brake pedal for the brain. It enhances the effect of GABA, which is the brain's main inhibitory neurotransmitter. It's constantly telling the brain to slow down.
Okay, foot on the brake.
If you hold that brake down for years, the brain responds by revving the engine harder and harder just to move. That's tolerance developing. It's pushing on the gas to compensate for the brake. If you suddenly take your foot off the brake, if you stop drinking, the engine is still revving at maximum speed. There's nothing to hold it back. The brain goes into overdrive. That overdrive is the seizure.
That is a brilliant analogy. It makes so much sense. And it explains why medical detox is so often recommended. You need to ease off the brake, not just snap your foot off it.
Absolutely. It requires medical supervision, often using benzodiazepines to act as a substitute brake while the brain slowly, carefully calms down.
Speaking of benzodiazepines, that brings us to the next category of depressants, the sedatives and hypnotics.
Right. Drugs like alprazolam, better known as Xanax clonazepam, lorazepam, diazepam, which is Valium, these are widely prescribed for anxiety and sleep.
And the symptoms look a lot like being drunk, right? Since they work on the same system.
Very similar. They work on that same GABA system, they're just more targeted. So you see slurred speech, poor coordination, swaying, drowsiness, but also some specific signs like nystagmus, that's a rapid involuntary eye movement, and hypotension or low blood pressure.
And the text highlighted something it called the withdrawal trap, with benzodiazepine withdrawal depending on which one you take.
Yes, this is a critical point, the withdrawal trap. It's all about a drug's half-life.
Which is what exactly?
Half-life is the time it takes for half the drug to be eliminated from your system. With short-acting benzos like lorazepam or Xanax, the half-life is short. So if you are dependent and you stop, withdrawal starts fast within 12 to 24 hours.
So the rebound is quick. You know something is wrong almost immediately.
Very quick. You connect the fact that you stopped the pill yesterday with feeling terrible today. But with long-acting ones like diazepam or Valium, the withdrawal might be delayed for several days.
Several days.
Yes. The drug and its active metabolites can stay in your system for over 100 hours.
Wow. So you could stop taking it, feel fine for 3-4 days and think, hey, I kicked it, this is easy, I'm fine. And then suddenly on day 5, you're in a full-blown crisis.
Exactly. You're at a dinner party and suddenly you have a seizure. And because it's been 5 days, people, and sometimes even doctors, if they aren't careful, might not link the seizure to the drug you stopped almost a week ago. It's a very dangerous situation.
The text also groups some other scary substances in this section, the so-called date rape drugs.
Yes, specifically flunitrazepam, which is known on the street as Rohypnol, and gamma hydroxybutyrate, or GHB.
These are used specifically because they disable the victim.
That's their nefarious purpose. Rohypnol is an extremely potent benzo. It causes profound sedation and amnesia. You literally forget what happened. GHB is similar. It causes amnesia, hypotonia.
With hypotonia.
It's low muscle tone, so you essentially become like a rag doll, unable to resist. And it can cause anesthesia, loss of consciousness.
And the withdrawal from GHB is particularly nasty.
It is. The text mentions it involves severe mental status changes, tremors, and agitation. It's so severe that benzodiazepines are often required just to control the agitation from GHB withdrawal. It's a very volatile substance.
Okay, let's pivot. We've talked about the things that slow you down, the brakes. Now let's talk about the opiate crisis. This is obviously a massive topic. It feels like this section is where the modern tragedy really lives.
It is. The substance list here covers the illicit, like heroin, but also, crucially, the pharmaceutical. Hydrocodone, oxycodone, methadone.
The source notes that hydrocodone is the most widely abused pharmaceutical-controlled substance in the U.S.
It's a staggering stat. It shows how this crisis really started in the medicine cabinet, not on a street corner.
So let's talk about the mechanism here. We use the brake pedal analogy for alcohol. What's the analogy for opiates?
Think of opiates as a master key. Your brain has these things called mu-opioid receptors. These are locks. When your body's natural painkillers, endorphins, turn these locks, they relieve pain and create a sense of well-being.
A natural system.
Yes, opiates are a master key that fits these locks perfectly but turns them harder and longer than nature ever intended.
So it unlocks massive pain relief, but also massive euphoria.
Exactly. It floods the reward center with dopamine, but it also does something else, something very dangerous. It depresses respiration. It tells the brainstem, hey, you don't need to breathe as much. That's how people die from an overdose. They just stop breathing.
So let's contrast intoxication versus withdrawal here. If someone is high on opiates, if they've turned that key, what are we seeing?
Intoxication is characterized by an initial rush of euphoria, followed by apathy and sedation. We call it the nod, where they drift in and out of consciousness.
And you mentioned a key physical sign.
Yes, the telltale sign for a clinician, the thing an ER doctor looks for from across the room, is the pupils.
The eyes don't lie.
Pinpoint pupils. Constricted. The medical term is meiosis. If you see someone who is sedated with pupils the size of a pinhead, you think opiates immediately.
And withdrawal, what does that look like?
Withdrawal is the complete opposite in every way. The brain, realizing the key is gone, swings the door wide open in the other direction. I often describe it as the worst flu you've ever had, multiplied by panic.
The text lists the symptoms, and they are visceral.
They are. Lacrimation, so you're crying, but not out of sadness. Your eyes are just leaking. Rhinorrhea, constantly runny nose. Piloerection.
Piloerection.
Goosebumps. That's actually where the term cold turkey comes from. The skin of someone in withdrawal looks like a plucked turkey.
I never knew that.
You also get diarrhea, yawning, fever, insomnia, and the worst part for most people, severe, deep-in-the-bone muscle aches.
But it's not just physical, right?
Yeah.
People describe this sense of impending doom.
Yes. The psychological distress, the dysphoria, is immense. It's not just, I hurt. It's, the world is ending and the only thing that will fix it is the drug. That's why relapse is so common during detox. The craving is overwhelming.
The source also noted that the timeline is different depending on the opiate.
Yes, like with benzos, it's about half-life. Heroin is short-acting, so withdrawal starts in just a few hours. But with methadone, which is very long-acting, withdrawal might not even start for 3 to 5 days.
That brings up a good point. Methadone is used to treat addiction, but it's dangerous in its own right.
It is extremely tricky to manage. Methadone is a long-acting opioid, which is why it's useful for treatment. But the dangerous part is the disconnect between its pain-relieving effect and its effect on breathing.
How does that work?
The analgesic effect, the pain relief, might wear off after, say, 6 to 8 hours. So the user thinks, I'm in pain, I'm starting to feel sick, I need more.
Okay.
But the respiratory depression, the effect that stops your breathing, that part lasts much longer. It actually peaks later than the analgesic effect and stays in the system for 24 hours or more.
So they take a second dose because they hurt.
But the breathing suppression from the first dose is still ramping up. The second dose stacks on top of it. They go to sleep and they just never wake up. It's a silent, tragic killer.
The text also mentioned a specific dangerous practice with oxycodone,
Well,
hillbilly heroin, as it was called in the media.
yes, crushing the controlled release tablets. Pills, like the original OxyContin, were designed with a special coating to release the drug slowly over 12 hours. A slow, safe trickle.
A brilliant medical technology in theory.
In theory. But abusers quickly realized If you crush the pill, you destroy that time release mechanism.
So the dam breaks.
Exactly. They snort or inject the powder and get the full 12-hour dose in 12 seconds. It's a massive shock to the system and carries a huge, huge overdose risk.
And we can't skip the speedball.
No, that's mixing opiates with stimulants, usually heroin with cocaine. You are pulling the heart and the central nervous system in two opposite directions at the same time.
That can't be good.
It's incredibly dangerous. The cocaine revs the heart up, the heroin slows it down. It creates a chaotic, unstable rhythm that can cause heart failure. It is one of the most volatile and dangerous combinations out there.
Which brings us neatly to the next section, the stimulants, the uppers.
And we start with the big one, cocaine.
So, mechanism of action. If alcohol is the brake and opiates are the key, what is cocaine?
Cocaine is the toy box jam.
The toy box jam. Okay, explain.
So, your brain cells talk to each other by throwing chemicals, neurotransmitters like dopamine back and forth across a gap. One cell throws the ball, dopamine, the other one catches it, and that sends a signal.
Okay.
Then, normally, the first cell has a little vacuum cleaner that sucks the ball back up to use again. That's called reuptake. It puts the toy back in the box so it doesn't just keep bouncing around.
Makes sense.
Cocaine jams that vacuum cleaner. It blocks reuptake. So the dopamine is thrown, but it can't be put away. It just bounces around in that gap, the synapse, hitting the receptors over and over and over again. It's a chaotic flood of dopamine.
That explains the intense energy and the euphoria.
Absolutely. But eventually, the brain runs out of dopamine to throw. The balls are all lost outside the box. That explains the crash. The text notes that the crash is profound depression, exhaustion, anxiety.
And because the high is so reinforcing, the source says 10% of people who start using it recreationally go on to heavy problematic use.
That's right. And the form it's taken in matters immensely for duration and addictive potential.
How so?
Snorting cocaine hydrochloride. The powder gives a high that lasts maybe 15 to 30 minutes. But smoking cocaine base, what's known as crack or rock, is almost instantly absorbed through the massive surface area of the lungs.
So it hits the brain faster.
In seconds. It causes this incredibly intense but very brief euphoria. The high only lasts 5 to 10 minutes.
That short duration must drive the compulsion.
Yeah.
You have to keep taking it every 10 minutes to maintain that feeling.
That is the cycle. That's why crack addiction is so notoriously difficult. It becomes a full-time job just to service the addiction.
And we already mentioned the cocathylene risk with alcohol. But what are the other physical risks from cocaine itself?
They are severe. Chronic snorting causes vasoconstriction, which can lead to nasal septal collapse, literally burning a hole through the cartilage wall of your nose.
Wow.
It's very hard on the heart attacks, heart failure, arrhythmias, and it can cause a psychosis that looks almost identical to paranoid schizophrenia. People get paranoid, aggressive, they have auditory hallucinations.
Now compare that to methamphetamine, meth.
The text notes that the systemic effects are very similar to cocaine-blocking reuptake, causing a release of dopamine, but with one critical difference: duration.
How much longer are we talking?
Cocaine's high is measured in minutes. Methamphetamine has a much, much longer half-life. The high can last for hours, but so does the damage.
And the physical toll is infamous. The source lists dental caries as a specific pharmacological effect.
Meth mouth. We've all seen the pictures. It's a horrifying sight.
Why doesn't it happen?
It's a perfect storm of factors. The drug causes severe dry mouth or xerostomia. Saliva is crucial for protecting teeth. Without it, decay runs rampant. Plus, users often grind their teeth, that's called bruxism, due to the muscle tension.
And their diet probably isn't great.
They crave sugary drinks to combat the dry mouth, and their personal hygiene often deteriorates. It's a recipe for total dental destruction.
The text also mentions skin picking, related to a hallucination called formication.
Yes, that's the tactile hallucination of bugs crawling under the skin, sometimes called meth mites. Users will pick and dig at their skin for hours to try to get the bugs out, causing terrible sores and infections. It's a very common sign of stimulant psychosis.
And where does it come from? The text mentioned cold medicine.
Yes, ephedrine and pseudoephedrine. These are the active ingredients in many over-the-counter allergy and cold tablets, like Sudafed. They are precursor chemicals that can be chemically converted or cooked into meth.
Which is why there are now federal restrictions on buying it.
Exactly. That's why you now have to show your ID to a pharmacist to buy Sudafed in the U.S., and why there are strict limits on how much you can purchase.
Okay, moving on to something that sounds innocuous but isn't. Bath salts.
A complete and total misnomer. These have absolutely nothing to do with bathing. It was a cynical marketing trick to sell them legally in gas stations and head shops.
How did that work?
The packages would say not for human consumption, which was a way to try to bypass FDA and DEA regulations.
What are they actually?
They are synthetic cathinones. They are designer drugs. Clandestine chemists take a known stimulant structure and just tweak a molecule here or there to create a new compound that technically isn't illegal yet.
It's a constant cat and mouse game with law enforcement.
It is. But because they are new and untested, we have no safety data. They are powerful sympathomimetics, fight or flight on steroids. The text lists the effects: extreme agitation, paranoia, violent behavior, delusions, and even suicide. Physically, they can cause liver failure and muscle breakdown.
You are essentially acting as a guinea pig for an unknown chemist.
That's a perfect description.
And finally, in the stimulant category,
No.
MDMA or ecstasy.
This is a bit of a hybrid. It's a stimulant plus a mild hallucinogen. It works primarily by causing a massive release of serotonin, which is the bonding and happiness neurotransmitter.
What's the specific danger here that the text highlights?
Neurotoxicity. This is the big one. The text states that MDMA destroys serotonin-producing neurons in animal studies and is considered neurotoxic in humans.
What does that mean for a user?
It means it basically burns out the wires that help you feel happiness and regulate your mood. Long-term, heavy users can struggle with chronic depression, anxiety, and memory issues because their serotonin system is damaged.
And the acute physical risks.
Hyperthermia is a major one. Overheating. People take it at raves, dance for hours in hot clubs, get dehydrated, and their core body temperature can spike to lethal levels, leading to organ failure. It also causes muscle tension and teeth grinding.
Okay, let's move to section 5. The hallucinogens, marijuana, and inhalants. Let's start with the most common and probably the most controversial one, marijuana.
The most commonly used illicit drug, though the word illicit is changing rapidly as states move to legalize it. The main active agent is delta-9 tetrahydrocannabinol, or THC.
The text makes a distinction about potency that's important now.
Yes, hashish, which is the dried resin from the top of the plant, is much more potent than smoking the leaves. And modern cannabis concentrates, dabs, waxes, oils are incredibly potent compared to the weed of the 1970s. We're talking 70, 80, 90% THC.
And there's a stat about addiction. I feel like people often say, you can't get addicted to weed. It's seen as harmless.
The text refutes that idea. It states that 1 in 10 marijuana users will become addicted.
1 in 10. That's 10%.
It's lower than for cocaine or nicotine, for example, but it's absolutely not zero. A cannabis use disorder is a real diagnosable condition.
What does that addiction look like? It's maybe not as dramatic as a heroin addiction.
Not usually, no. But it involves that social impairment bucket we talked about, a loss of motivation, what's sometimes called an amotivational syndrome, using it to cope with all emotions, spending too much money on it, and feeling anxiety or irritability when you don't have it.
And what about spice or K2, these synthetic cannabinoids?
These are incredibly dangerous. Similar to bath salts, they are inert plant material like potpourri that's been sprayed with random powerful chemicals made in a lab.
These are synthetic cannabinoid receptor agonists.
Yes, but they don't behave like THC. They bind to the cannabinoid receptors with super strength and can have bizarre, unpredictable effects.
So why are they worse than natural marijuana?
Because they're full agonists and much more potent. The toxic symptoms are far more severe. We are talking seizures, hypertension, intense hallucinations, kidney damage, and psychosis. And suicidal thoughts and behaviors are strongly linked to them. Again, it's the unpredictability. You have no idea what chemical you are actually smoking.
Okay, let's talk about a classic hallucinogen, LSD acid.
LSD is very interesting pharmacologically. The text notes it produces tolerance very rapidly. If you take it 2 days in a row, the second day won't do much at all. But it is not considered addictive in the traditional sense.
Wait, really? Not addictive?
Correct. There is no withdrawal syndrome listed in the DSM-5. It doesn't seem to engage the dopamine reward pathway in that same compulsive way. People generally don't binge LSD for days on end like they might with crack cocaine.
So what does it do?
It causes profound perceptual intensification, depersonalization, a sense of being detached from your body, and synesthesia.
Synesthesia.
That's the crossing of the senses. You might hear colors or see sounds. The sensory processing centers of the brain start communicating in ways they normally don't.
That sounds intense. But the text mentions a long-term risk. Flashbacks.
Yes, that's a recognized condition called hallucinogen persisting perception disorder, or HPPD. It's the re-experiencing of the perceptual effects long after the drug has left the system. You could be driving down the road 3 months later and suddenly the lines on the road start waving and breathing.
And finally, inhalants. This is the stuff under the sink. Glue, paint, gasoline, aerosol cans.
This is often a drug of opportunity for younger people because it's so accessible, but it is incredibly, incredibly toxic. The text states that it is toxic to virtually all organ systems.
Why is it so bad for the brain?
Because the solvents in these products dissolve fatty tissues, and the brain is mostly fat. It literally causes brain damage.
And it can kill you instantly.
Yes. It's called sudden sniffing death syndrome. It can happen from arrhythmias, the heart just stops beating correctly due to a sudden surge of adrenaline, or from suffocation, often because people use plastic bags to concentrate the fumes.
It's just tragic. Okay. We have scared everyone sufficiently with the effects. The damage is clear. Now we have to talk about the solution. Section 6, the science of treatment.
Right. Treatment is complex because you have to manage 3 different phases. You can't just treat addiction as one thing. You have to treat acute intoxication, the overdose. Then you have to manage withdrawal, the detox. And finally, you have to address long-term dependence, the recovery.
Let's start with intoxication. Someone comes into the ER and they are overdosing. What do we do?
The general rule is avoid giving more drugs if possible. The main thing is supportive care. Make sure they're breathing, monitor their heart, keep them safe from hurting themselves or others. But if there's a specific antidote, we use it.
We hear about Narcan on the news all the time.
Naloxone, or Narcan. It is a pure opioid antagonist.
Okay, let's explain that term. We had agonists, which are the key. What is an antagonist?
An antagonist is something that fits in the lock, but doesn't turn it. In fact, it jams the lock, or in the case of naloxone, it's so powerful it kicks the heroin key right out of the lock and takes its place, blocking it completely.
So it slams the door shut on the opiate's effects.
Instantly. It can revive unconscious patients who have stopped breathing because it immediately knocks the opiate off the receptors in the brainstem. It's a miracle drug. But the expert note here is crucial. It precipitates immediate, severe withdrawal.
So you wake them up, but do you wake them up into that worst flu of your life state instantly?
Instantly and violently. They can wake up combative, vomiting, screaming in pain. It's not a gentle awakening. It's a biological explosion, but it saves their life.
And for benzodiazepines, is there a similar antidote?
There is one. It's called flumazenil. It's also an antagonist. But the text warns it is often contraindicated, meaning we often don't use it. Seizure risk. Remember our brake pedal analogy. If someone is physically dependent on benzos and you suddenly block them with flumazenil, you are ripping the brake pedal out of a speeding car. You can trigger a massive life-threatening seizure right there on the spot. So doctors use it with extreme caution.
Okay, so that's the emergency phase. Now the patient is stable, but the drug is leaving their system. Withdrawal management or detox. Let's look at alcohol first.
The standard of care, the gold standard, is benzodiazepines. Specifically, the text mentions symptom-triggered lorazepam.
Wait, so we treat alcohol withdrawal with another depressant. That seems counterintuitive.
It's the only way to do it safely. Since alcohol and benzos both work on that GABA brake pedal, they are cross-tolerant. You use the benzo to substitute for the alcohol to keep the brake slightly applied so the brain doesn't seize up.
I see.
Then you slowly, carefully taper the benzo dose down over several days. It's a controlled landing rather than a crash.
And the text also mentions thiamine.
Yes, vitamin B1. This is critical. Chronic alcoholics are often severely malnourished and B1 deficient. If you give them sugar, like in an IV, without replacing B1 first, you can trigger a devastating condition called Wernicke-Korsakoff syndrome.
Which is?
It's permanent brain damage that, among other things, prevents you from forming new memories. It's a preventable tragedy.
Now, detox for opiates.
We have a few good options now. Methadone is the classic one. You replace the short-acting heroin with the long-acting methadone, and then slowly taper the methadone dose down.
Or buprenorphine.
Right. Buprenorphine is fascinating. It's a partial agonist.
Okay, sticking with our key analogy, agonist is the key, antagonist is the block. What is a partial agonist?
A partial agonist is a key that fits in the lock, but it only turns the lock about halfway. It opens the door just enough to stop the cold wind of withdrawal from blowing in, but not enough to throw the door wide open and cause intense euphoria or dangerous respiratory depression.
So it has a ceiling effect.
Exactly. It has a built-in safety mechanism which makes it much safer than methadone, especially for starting treatment outside of a hospital.
The text also mentioned clonidine. That's a blood pressure med, right?
Yeah.
How does that help?
It is. It works by blocking the adrenaline surge of withdrawal. So it helps with the autonomic symptoms, the sweating, the racing heart, the agitation, the goosebumps. But it does absolutely nothing for the craving. It treats the body, not the desire.
Okay, so the patient has detoxed, the drugs are out of the system, they're clean. Now comes the hard part, treating dependence for the long haul, preventing relapse.
This is where the real work begins, because the detox is just the first step. The brain pathways are still wired for the drug. For alcohol, we have a few pharmacological tools to help reprogram the behavior.
Let's talk about disulfiram, or antabuse. This is the aversion strategy.
It's basically psychological warfare against the addiction. It works by inhibiting that enzyme we talked about earlier, aldehyde dehydrogenase.
Yes, second step in the factory line, the one that gets rid of the toxin.
Exactly. So if you take antabuse and then you drink alcohol, the alcohol gets turned into toxic acetaldehyde and then it gets stuck there. The toxin builds up in your body.
And what does that feel like?
You get violently ill within minutes, flushing, a pounding headache, projectile vomiting, heart palpitations. It feels like you are having a heart attack. The text warns that even alcohol-containing mouthwash or aftershave can trigger it.
So it's a deterrent.
Yeah.
You take the pill in the morning and I absolutely cannot drink today because if I do, I will suffer terribly.
Exactly. It buys you a 24-hour window of safety to work on your recovery. Then there is naltrexone. This is an opioid blocker, an antagonist, but it works for alcohol too.
How does an opioid blocker help with drinking? That seems strange.
Because part of the pleasure of alcohol comes from the release of our body's own natural opioids, endorphins. Naltrexone blocks those receptors. So if you drink while taking it, you might get the dizziness and the slurred speech, but you don't get the euphoria, the buzz. It uncouples the action from the reward.
But there's a huge danger there if you're also using opiates.
A massive danger. If you are physically dependent on opiates and you take naltrexone, it will rip the opiates off the receptors. It will cause immediate, severe, precipitated withdrawal. You have to be completely opiate-free for 7 to 10 days before starting it.
Finally, let's talk about nicotine. The text calls it the leading cause of preventable morbidity and mortality.
It is. Nicotine is incredibly addictive. The behavior is reinforced dozens, sometimes hundreds of times a day. We have NRT nicotine replacement therapy, gum, patches, inhalers.
There was a specific tip about the gum that I had never heard before. Chew and part.
Yes. This is so important. Most people use nicotine gum wrong. They chew it constantly like it's bubble gum. If you do that, you swallow the nicotine-laced saliva. It goes into your stomach, causes nausea and hiccups, and is mostly destroyed by stomach acid.
So it doesn't work well. What's the right way?
You chew it just until it tastes peppery or you feel a tingle. That means it has released the nicotine. Then you stop chewing and park it between your cheek and gum. The nicotine is then absorbed through the mucous membrane of the mouth directly into the bloodstream.
Like chewing tobacco.
Exactly. When the tingle fades, you chew it a couple more times, then park it again. That's how it's designed to work.
That is a news you can use tip right there. And the pills. Zyban and Chantix.
Bupropion SR, or Zyban, is an antidepressant that was found to help with smoking cessation. It keeps dopamine and norepinephrine levels slightly higher, so the craving isn't as intense. But you can't use it if you have a seizure disorder or an eating disorder like bulimia.
And Varenicline or Chantix.
That's a partial agonist for the nicotine receptor, just like buprenorphine is for opiates. It tickles the receptor enough to reduce withdrawal symptoms, but it also blocks the nicotine from cigarettes from fully binding. So if you do smoke, you don't get the same pleasure from it.
The source says it has a higher success rate.
It does. But there's a warning from the text to watch for erratic or aggressive behavior and suicidal thoughts. It's a very effective medication, but it requires monitoring.
It's a balance of risks and benefits.
Always.
Always in medicine. So we have covered a massive amount of ground here. From the 5 C's of addiction, to the deadly math of alcohol withdrawal, to the neurotoxicity of ecstasy.
It's a landscape that requires a lot of respect. I think the key takeaway is that we have to understand that addiction is a chronic neurobiologic disease. It is not a failure of willpower. It is a hijacking of the brain's most basic survival mechanisms.
And the transition is so subtle and so insidious. You go from getting high, the intoxication phase, to just needing to feel normal, the withdrawal prevention phase.
That is the tragedy of dependence. You aren't chasing a high anymore. You are running away from the pain. You are completely trapped by your own biology.
I want to leave the listeners with a final thought from the source material. It was a sentence, just one sentence regarding opiate treatment that really stuck with me.
Okay.
It said, regardless of detoxification strategy, most heroin users relapse.
It is a sobering statement, but it's an important one. It highlights the most important takeaway of all. Detox, getting the drug out of the blood, that's the easy part. That takes a week. But recovery, fixing the life, the habits, the neural pathways, the social buckets we talked about at the very beginning, that is a lifelong management issue.
It changes the goal from finding a cure to finding management, like with a chronic disease like diabetes.
Exactly. You don't cure diabetes, you manage it every single day with diet, exercise, and medication. Addiction is no different. And understanding the biology, everything we've talked about today, is the first crucial step to managing it effectively.
Thank you for walking us through this deep dive. It's heavy, but I think knowledge is safety.
My pleasure. Stay informed.
See you next time on the Deep Dive.